Thank you to all our people living with HIV leaders and networks at the global, regional, and country level. This is another exciting convening, and thank you so much for your time joining us. So in the last IS, there has been several guidelines that the WHO has launched, including guidelines on antiretroviral therapy. And as of this moment, there are several researches and studies on long-acting ART and other combinations or new drug combinations of antiretroviral therapy. Now, the antiretroviral therapy is not only beneficial to one population group, but it benefits all people living with HIV across age, across gender, and across countries and regions. In delivering the ART services, we have several methods and models, and today at this convening, we will also learn about the different DSC models which has emerged as critical approaches in ensuring that we are still able to access equitable and effective ART despite the reprioritization, integration, and the decrease in funding. And we will be welcoming our PLHIV leaders from Uganda, from Kenya, and from Malaysia, who will be sharing their own work at the country level towards delivering ART services to people living with HIV. So without further ado, my name is Inad Quinones Rendon. I am the Community PLHIV Engagement Officer of GNP Plus, and here are our panelists. Let's start with Florence. If you can introduce yourself first.
Hi, thanks, Inad. My name is Florence Riakwanam. I am one of the co-executive directors at the Global Network of People Living with HIV. Welcome.
Thank you. Marco?
Good morning, good afternoon to everybody. My name is Marco Vittoria. I'm a medical officer of the HIV, TB, hepatitis, and STI department in WHO Geneva.
Thank you. Esteban?
Pleasure to be with you. This is Esteban Burrone. I head the policy, strategy, and market access teams at the Medicines Patent Pool. Pleasure to be with you.
Thank you. Anna?
Hi, everyone. Thanks for the invitation. I'm Anna Grimsrud. I'm with IAS. I'm a senior technical advisor, and I'm based in South Africa.
Zairu?
Hi, everyone. My name is Nyanzi Zairu. I am the Executive Director, Gender Network of Young People Living with HIV in Uganda. We work with young people, particularly in the communities of Uganda. Thank you.
Thank you so much. And we will also be hearing from our panelists who will be joining us a little later. Thank you so much. Please make use of the chat. Feel free to network with yourselves. We have the Q&A chat box for any questions. This convening is recorded, and we'll be sharing all the presentations to you after. Now, to set the scene, before we proceed with the very interesting discussions on ART, I'd like to invite GNP Plus Co-Executive Director Florence Riakwanam. You have the microphone.
It's a pleasure to be here because when we started these sessions at the start of this year, it was just to come in and talk about how do we prepare to jointly engage in the global AIDS strategy and to plan for the high-level meeting next year. That was the intention, which quickly went up in the air because threat to our access to treatment became real for us after January 21st this year. But we still came here, a few of us, and the numbers have grown over time, to share with ourselves and to give each other motivation and strength in a trying period. For the longest time, many of us have been assured that our treatment will be available, and we have worked tirelessly to address the barriers to accessing this treatment, worked with partners who are sitting in this room to ensure policies and interventions reach all people living with HIV. However, that was shaken this year, and we have come here every day, learned from countries, learned how country networks of people living with HIV are engaging with their governments, learned from our experiences at different levels what these changes have meant to us. On the back end of this, at a very difficult time, the World Health Organization was also updating treatment guidelines. And in doing that, they did commission GNP Plus to engage in values and preferences to inform these guidelines, an honor that we took seriously, but also was not possible if you all did not participate in the surveys we asked you to participate in, and in the key informant interviews, and in the discussions that we convened with you. So that informed the guidelines, and we are very proud that we were able to engage with this process in this way, and that's why it's an honor for Marco to join us and update us on those guidelines. I believe that IIS also was a pivotal point, organizing us all in the just concluded IIS Scientific Conference, and there's lots of updates that we will get from there. And I think the message here is clear. Our role as people living with HIV leaders started off to ensure that we have access to treatment and HIV services that are responsive to our needs. And no matter what happens, that must be the grounding of our work. And we are here to figure out how to do that better. I want to just say a few things. We at GNP Plus were tasked by people living with HIV as we met in April to bring us all together in defining minimum standards of integration of HIV services into primary healthcare for UHC by people living with HIV. We put out a survey. We've had 2 consultations, but we put out a survey and over 1,800 people responded to that survey, showing how significant this topic is for people living with HIV and those affected by HIV. Thank you all for doing that. Our report is forthcoming and we are hoping to launch it at World AIDS Day. So please stay tuned for that. I would like to welcome all our guests who are coming to discuss with us. These convenings have continued to grow and bring in all subject matter experts. We want to learn from you, but this is also a demonstration of how HIV is a multi-sectoral, multilateral space. Addressing the response requires all of us. We also know from HIV response that the greatness and the impactfulness of science is only possible if people living with HIV are in the middle of it. I'm looking forward to what we will learn today. Please use the chat box. Please learn among each other, share your experiences at country level, and let's learn together about what's new in the science, what potential exists out there, what could we do together, and how can we work in our leadership to ensure that all people living with HIV are on treatment, are not only on treatment, but virally suppressed for our own healthcare and our own quality of life, but also to contribute towards HIV prevention, because undetectable equals untransmittable. Thank you, and back to you, Enad.
Thank you so much, Florence, for the. Sorry, my background is gone, but that's okay. Thank you so much, Florence. We are very happy that we are joined here by our PLHIV leaders and networks from the country level. No, our next presenter, I have met this next presenter like a few years ago, and it was from him that I've learned about the dolutegravir before it was even discussed within the PLHIV community. So I'd like to welcome Marco Vittoria from the WHO to share some overview on what are the sciences or the studies on ART, on antiretroviral therapy and long-acting antiretroviral therapy. Marco?
Okay, thank you very much, Inand. And I'd like to join the comment from Florence about the thanks to the GNP Plus and the community to help us in the process of update our ART recommendations that are now in final stage for publication. I'm really sorry to not have it already in online in full. We have just released a very brief document during the last IS conference, but we are now finalizing the clearance to publish the document in full. As we all know, you already have included for the first time in WHO guidelines long-acting ARV combination for treatment, and also added other options of long-acting for prevention. With the lenacapavir as a not for prevention, that are important achievements, I think, can really make us really move towards a better access and better treatment for people and prevention for people living with HIV. Well, the objective of my talk is very quick, just to give you a very rapid fire on what is the current status of the potential long-acting agents that are being in development or planning to be developed. Just to let you know that for next year, we are now following very closely now this, and we are planning to have a specific guidance on this area in terms of what are the target product profiles, and also try to revise the previous priority drugs in our CADO and PADO lists that I think certainly can help us in the discussions, and I already count on you to be part of this process next year. Well, this slide is just to give the sense of the temporal evolution of the pipeline in the last 40 years. As you can see, for those that are in this field for long, you can compare what you have in the past and what you have now, moved for a very, very challenging regimens with too many tablets, taking several times a day, moving progressively for more potent and less toxic options, going to a momentum where you have a very good regimen like tenofovir, TTC, dolutegravir, that is 1 tablet once a day, that has been the major drug currently on use at global level. More than 90% of people are using this regimen, and with several advantages. However, as you know, this is not a perfect regimen, and there is no silver bullet against HIV. And we start to move to a new phase, and then being another options coming as the long-acting, injecting, even oral options are in the pipeline. And I briefly will talk about this, but just to give you the sense, the importance in how HIV treatment has been a good example of a movement towards innovation and bringing it to a more global level. I think the good examples on how the science has been very important in terms to really impact not only the mortality associated with the disease, but also about the quality of life of people living with HIV. Well, this is just to also give the sense in how this optimization process evolve in terms of innovation. I try to divide in basically 3 periods, as you can see. In the beginning, in 2010 until 2015, the work was more about what you can do to improve the available drugs, trying to really simplify manufacturing process. The major focus at that time was really to reduce the HIV mortality, try to prevent the disease progression. Really, preservation of life was the main point at that time. It was evolved between 2015 and 2020, several innovations came. We start to look not for new drugs and also new formulations, looking for improved efficacy, reduced toxicity, looking for durability of the regimens, looking carefully about how can you get regimens with higher genetic barrier, also looking for less complex regimens, trying to simplify the sequencing of regimens, and also looking carefully about how to harmonize the regimens across different populations, trying to make it simple, not for adults, but also for kids, for pregnant women, for people with specific co-infections, and also start to look carefully about how treatment can impact the transmission of HIV. And then after 2020, we start to look more carefully about new technologies, not just about the drugs itself, but the process of to make long-acting regimens really evolving. Then drug delivery less frequently, in a smaller number of tablets or a number of applications, using lower doses. And we start to look very careful about how to make the service delivery platforms for injectable regimen become available. We start to look, okay, what adjustments needed for a better programmatic delivery of these new regimens. We start to look more careful about sequencing a more orthogonal approach, trying to not move to one size fit all, and also start to harmonize not only about treatment, but also harmonize across prevention, PrEP and PEP, and start to look more careful about how multi-purpose technologies can be applied. For example, how can you have ways to administer PrEP and contraception in one reg? This is coming from now. Since 2020, we are looking at these issues as evolving progressively. And looking more careful about the long-acting framework, This is just to give what is the WHO perspective in terms of the expected, or let's say desirable evolution of the long-acting agents for HIV. Currently, we are in a kind of situation where individuals, drug formulations for PrEP are available, like CAB and LAN, and also some of these drugs has been used in salvage regimens, like LAN. Cabotegravir was the only dual regimen approved, and now including WHO guidelines. It is being used every 2 months intervals, separate injections, intramuscular. Are several concerns around impact on resistance, several is about drug interactions, but this is the first step on it. We are looking very carefully about the implementation studies in low mid-income countries, and also recognizing that despite of this a lot of enthusiasm around these new regimens or new options, there is a very limited availability of these drugs yet, and at high cost, and important implementation challenge in order to make it more available and affordable everywhere. And what they are looking more from now in the short, let's say short, medium term, well, it's very clear for us that one of the most important targets now is to expand PrEP using LAN and CAB, increasing availability and reducing cost of production of the single formulation. This is already a process ongoing. There is a lot of discussions in several forums, and I believe that in the next international conferences, this will be one of the important topics, and WHO is looking very carefully, trying to really improve the normative framework, quality assurance, trying to really make these drugs more available and promote access to PrEP options, including LAN. The long-acting combinations with current available drugs, or those in phase 2, phase 3, that have better clinical and programmatic profiles. For example, we start to look more carefully, looking for move away from bi-monthly or even monthly regimens, trying to move to 3 to 6 month intervals, moving from intramuscular to subcutaneous injections. Maybe in some situations, even oral rest can come in the future. You also have more target now for this short, medium term for populations that are facing adherence challenge with oral regimens. This is one of the key populations that are target populations that we want to really look very carefully, where the impact of this new technology can bring a lot of benefits from a public health perspective, and also carefully looking the efforts to develop of generic formulations of these new options in order to make it more available and affordable. And looking for the long term, of course, you want to expand access to long-acting treatment and prevention regimens, increasing availability and reducing costs of the production of dual combinations that can come in the future. Options that are looking, but still very early to say, are leading long-acting combinations with current, but also looking new drugs or new classes with optimized profiles, giving, for example, the drugs by every 6 months or even 12 months, subcutaneous, self-administered, as you see current with other diseases like the GLP-1 agonists for obesity, implants, long cross-resistance risk, and less cross-resistance risk, and also less drug-drug interactions. And definitely the use of the simplification treatment strategies and expanded use of prevention beyond the current PrEP indications. For example, the postnatal prophylaxis, that can be also an important area that need attention. Well, this table is just to very quickly to inform what are the long-acting antiretrovirals and monoclonal antibodies, because they're not just about small molecules, but also looking for some immunobiologicals that can have a role on treatment and prevention for use in clinical management of HIV. Well, basically, you can still have cabotegravir and long-acting ribavirin are the major ones for treatment for now. Cabotegravir is, as you know, is an integrase inhibitor, has been indicated for prevention and treatment, is using for your intramuscular route, and the dose interval approval for now with the current formulations every 2 months. Long-acting ribavirin is a non-nuke that is available even in the past as an oral regimen, but now have a long-acting formulation, is not used for PrEP, is just for treatment, and is being used paired with cabotegravir every 2 months. Lenacapavir is a capsid inhibitor, is a new class of drug, different class of drug. It is a drug that has been approved for prevention and also for treatment. But for treatment, the use has been basically approved for in conjunction with other oral drugs as a salvage regimen in heavily treated patients with drug resistance. There are current studies under investigation of oral formulations combining it with other oral ARVs, for example, lenacapavir and bictegravir, and also weekly regimens like lenacapavir islatravir. I will show something about it later. And also regimens in naive and switching patients. There are additional ongoing research in focus on subcutaneous formulations combined with broad neutralizing antibodies and also cabotegravir. There are also ongoing studies on intramuscular lenacapavir formulations for PrEP in annual dosing. There are other two drugs that are less commented that I like to comment here. Albuterol is an entry inhibitor that is not approved for PrEP, but has been used for treatment, but has been approved only in China for salvage regimens. However, is a drug that has been now studied in combination with some broad neutralizing antibodies. However, the use should be intravenous and the dose should be weekly or biweekly. Then is a drug that, despite to be approved in some countries, is not largely available and still under investigation in combination with other drugs beyond this, the use as a salvage therapy or a kind of maintenance in people already suppressed. And you have a monoclonal antibody, the ibazilimab or IBA drug, is also approved for treatment. And again, as you commented before, for lenacapavir, is a drug used mainly in salvage regimens. Is an intravenous drug used every 2 weeks. Then this is what already exists in our portfolio, with the emphasis on the first 3 drugs that has been more used, Cabril for treatment mainly, and Len for prevention and treatment. What about what's coming in terms of new long-acting that are under investigation now? As you can see, I don't go in details, but what I like to emphasize here in this slide, there are several new candidates from different classes. The major focus on these drugs has been oral regimens used in weekly basis. There are several of these drugs can have activity against resistance virus or to current drugs that we are using today. And some of these candidates, unfortunately, has been stopped in their studies because of some lymphocyte toxicity identified on initial trials. But again, there is a perspective here that some of these drugs can be used as a weekly basis in oral, despite to have some promising drugs also in injecting subcutaneous every 6 months with activity against resistance virus. Moving to phase 1, it's a very early stage that is in more uncertain about what to be the role in the future. You also have several early candidates. The main emphasis here has been in every 3 to 6 month dosing, and subcutaneous become an issue here. That's important for us, I think, to make the process more easy to administer, but have implications for implementation, but also include some oral drugs. Many of them are, in fact, prodrugs of drugs that already been studied before, that can make the process more safe in terms of drug interactions, maybe reduce toxicity, and also make the product more easy to be administered in more long term, every 3, 6, or even more months. In terms of broad neutralizing antibodies, that is a kind of important class that has been studied not only for treatment, but also in the cure arena for the very long-term future. You also have a list of several of them that are in study. What's important to say that it's very early to really imagine how can we use it in combination for the drug. There are several trials ongoing, but they are mainly drugs that act binding in the specific part of the virus or a CD4 binding site of GP120 or in the mapper site of GP41. They have more blocking the entry of the virus in the cells. The main route of use of these drugs has been intravenous for a while. That is an important challenge. But as you can see, the dose schedule is quite attractive every 6 months, every 4 months. That has been more adequate in a public health perspective. Again, there are several of these drugs that have been used in combination with other antiretrovirals, and I believe that this is a kind of a drug that can be explored, particularly in the prevention and also in specific situations where people have a multi-drug resistance. This is just to give you a kind of overview of in terms of the pipeline, looking for the use of every week or every 2 weeks, monthly, bi-monthly, every 3 months, every 4 months, and also every 6 months. As you can see, there is a lot of drugs that has been used weekly for now, that mainly oral options, but we also have several drugs, particularly in early stage, in every 6 months. That will be subcutaneous mainly. Another way to see this table is looking for the ARV class, but what is the clinical stage in terms of studies? As you can see, there is a lot of drugs in phase 1 and preclinical. That means that you need to wait a little more to know exactly if they will evolve or not. But there are some drugs in phase 2, mainly oral drugs, as I commented before. But there are some few drugs in phase 3 that are more close to be launched as an option for treatment. But we need to learn more about this probably in the next conferences where we know more about these drugs, particularly those in phase 2 and phase 3. What are the major ongoing studies? I like just to inform there are several phase 2 studies and they're in mid stage that are more focused on dosing in the strategy itself. And there are some in phase 3 that are looking for something more for pre-approval for clinical use. In terms of once weekly oral, you have here a couple of studies, the ISLAND-1 and ISLAND-2, that are looking the combination of lenacapavir and islatravir that can be an option. They are looking mainly in people that are already suppressed. You have other options like some prodrugs for LAN and also some new integrated inhibitors that seems to be very promising in the initial studies, the GS4182 and the GS1720. These drugs has been evaluated in the WONDER studies both in virally suppressed and in naive individuals. This is a Gilead-sponsored study, but this study was put on hold in June because of some CD4 toxicity detected in the trials. Then I'm still waiting more information. The same problem was identified in the past with islatravir using higher dose. That's why islatravir studies using, for example, every 3-6 months were suspended, and now using islatravir in weekly basis because the dosing don't create problems in terms of lymphocyte toxicity. There are some studies also combining islatravir with the MK-8507. That is a drug that also being studied as a standalone option for PrEP. This is a study that's been sponsored by Merck. I think you will know more about this in next CROI. In terms of injectable options, I think there are some studies ongoing with cabotegravir long-acting monthly plus BNABs every 4 months. Is a more complex study. The name is Embrace. Is also a pharma-sponsored study from ViiV. And we are paying a lot of attention now in the studies with cabotegravir ultra long-acting formulations that can allow us to use, instead to use every month or bi-monthly, maybe you can go to every 3-4 months. There's a kind of option that can facilitate, but you need to find a good partner for this drug in the future. And in terms of injectable every 6 months, the one that you know very well, LAN, has already been approved. The proposed trials clearly show the benefits of this for PrEP. There are some studies on LAN plus BNABs like TAB and ZAB. the studies are ongoing. I think you know more about these studies in next CROI. And more recently, you have the announcement of the study results of the study of lenacapavir for prevention intramuscular injections, but every year that can be important for prevention too. Then you need to know more about it in the future conferences on it. However, despite of these initial comments about these new drugs, I think there is one important study that we need to pay a lot of attention, looking very carefully for the near future, is the studies combining lenacapavir plus cabotegravir. The studies were recently approved. There are the two studies that are listed here. These CTG trials. The studies are looking for use this combination in people facing adherence challenge, including those that are viremic. That I think is a very important topic, because currently the use of cabotegravir ribavirin for treatment, for example, is approved for use from WHO, but in people that are facing adherence challenge but are still suppressed. But you need to know more about, okay, for those that are failing or not tolerate well the oral regimens are viremic. That's important option that need to be considered. Then I believe that lenacapavir plus cabotegravir is a kind of low-hanging fruit in terms of the evolution of the long-acting treatment that WHO will look very carefully in order to monitor the studies and see how can we implement it when you have more data. Currently, the data is quite limited. You have basically few demonstrative studies, projects that cannot make any recommendation about the use of these two drugs for treatment, but it's a good expectation that the results of these trials can bring more information and allow us to consider this for inclusion in our guidelines in the future. Then just to finalize, I think just to give some important takeaway message, as you can briefly saw in my presentation, the landscape of these long-acting therapies is a rapid evolving field. You have a lot of options in the table now. There is a strong focus on less frequent dosing, looking for new drug classes, and also combinations of different regimens. There are multiple phase 2 and phase 3 studies ongoing now, including combinations of long-acting and antibodies, and new dosing strategies and weekly regimens that we need to understand better what would be the role of it in public health perspective. The annual intramuscular len for PrEP is also important breakthrough that is coming. There are several products that are in the preclinical and phase 1 stage that are still very unknown, but we need to look how it will go. There's a trend on these regimens to promote longer dose intervals in these combination therapies. BNABs, as I think is a for more long-term future, is an area of research, especially combined with other long-acting agents, but intravenous administration for a while remains an important challenge. Need to see if we can evolve with these drugs in more friendly administration formulations. And the field is very dynamic with new agents and formulations being tested for both treatment and prevention. It's important to try to maintain both areas open for that. Then, basically, what is in the horizon now, also weekly oral regimens, islatravir and lenacapavir, I think are several studies on it. Islatravir plus lornovirin, I think is also important, right, that you need to know more about it. I think in the near future, you know more about the studies that are ongoing. There are no new long-acting drugs or formulations in development, as there is the MK-8527. This is a once monthly NRTTI that has been considered for PrEP. LEN also yearly, ultra long CAB, and as I commented before, CAB plus LEN combination are probably what is in the, let's say, more close in the horizon. In more long term, need to pay attention to this phase 1 new integrase and capsid inhibitors, all these VH and GS drugs that are presenting tables there, and looking for the use of long-acting like CAB plus LEN or LEN plus and BNABs. This is what I want to show you. Thank you very much for attention. If you have a couple of questions, I can answer. Thank you.
Thank you. Thank you, Marco, so much for the very, very informative presentation. So Marco won't be able to join us for long. So do you have any questions for Marco? Okay, just gonna recap. So from Marco's presentation, we have learned about the different okay, Kenley. I'll you can talk now, Kenley.
Thanks, Marco, as always. Hi, very useful. Just a quick, just for the community, my community colleagues to understand. I think it's been exciting to see all these new molecules and see WHO move so quickly to bring new technologies, make into the guidelines and therefore into our countries. Now, for learn and for prevention, which is great, but we have also learned that the manufacturer, Gilead, is delaying studies for treatment, primarily because they're worried that uh, they're trying to preserve land for prevention much longer, so they can actually work release until they release their once yearly injection, and therefore don't want to risk any resistance rising through use in treatment. Can you maybe just enlighten us?
Yes,
Because we
yes.
keep receiving a lot of concerns from our
This
community
is a
colleagues.
debate. This is a
Yeah.
debate that is coming even among some experts about if you should preserve land for prevention and put cap for treatment. This is some people defend this position that you need to make this. As I said, I think that you need to get more information about what is the real risk of land resistance, that you don't have a lot. The drug seems to be a good profile in terms of resistance, but as you know, capsid inhibitors are the new class that we're still learning about that. I think that from WHO perspective, our plan is I think we need to move with both things together. We need to see what the evidence shows, but I don't think that is wise to start to block based on concerns without having any data showing that resistance can be a problem. Just block the use for land for treatment. I don't think that would be a good idea, but it's part of the plans that you have for update our CADO PADO ResNet meeting next year, is because this meeting was supposed to happen this year, but because of all this change in WHO, we are postponing that and try to organize better. But this is one of the topics that probably will be discussed there. I think that by principle, I think that you cannot make this dichotomy. Only if you start to see, of course, options, that you need to see how the other options evolve, and also to see exactly how can we manage the resistance. Because we have several past examples with other diseases where people try to make this kind of concern, but in practice, you never identify this situation. I would be more open from now, but this is an important topic for discussion among the community, including HIV community and academics, also about this strategy. Should you maintain both for both things, carbon land, or should you maintain land more for prevention and carbon more for treatment? I will be more. At this stage, I'll be more open. I think you need to know, you need to learn, you need to know more about what's the real evidence on resistance risk increase when you start to do it.
Thank you. There's another question. I think we're gonna get one more question for Marco. Mona, you're able to speak now.
Okay, thank you, Ned. So my question is what about the previously taken treatment? If the person living with HIV, if the person who want to take the LEN and previously he has taken hepatitis B or currently on hepatitis C treatment, and some of community member are taking the cancer treatment. So is there any contradictory effect evidence are available?
You talk about drug-drug interactions, no?
Yes.
This is one issue that we are discussing there, because currently, because of specific drug interactions, some drugs, I don't know about it, but I need to check the table. For example, rifampicin is a problem. Then the recommendation is not in the case of you using TB, probably you should use an alternative PrEP option, probably is what I think is recommended. For hepatitis drugs, I don't remember. I need to check I usually go, I like we usually evaluate it with the Liverpool drug interactions because they use a great process that's what WHO adopt for guidelines. Then I think, but you need to check. Sorry, I don't know. I can check in reply by email, but I don't remember exactly what are the potential implications. But you need to pay. This is one of the main challenges with long-acting drugs because when you start to use it, you need a kind of a drug that can have interaction. It can compromise or the antiretroviral or even the other drug, depending on the kind of interaction. And it's a long-term drug that's difficult to just make any kind of adjustment in the regimen. Maybe you need to use an alternative option to cover the needs of the patient. But for this specific case, I need to check because I don't have it in my mind now.
No worries. Thank you, Mekro. And the other thing is like, suppose if any male or female sex worker previously used that oral pills of PrEP. So and again, like if they have taken that long acting, so is there any further resistance for the same medicines? Because long acting, like now we like it's happened that contradict or any further resistance. Yeah.
Resistance is an issue. Is one of the topics that you need. That's why the new when you look for the drugs in the pipeline, many of them is already looking for options that are, let's say, they can address people that have specific resistance to the drugs. Again, the data are already really limited. As the use of these drugs are quite limited, you know that some cross-resistance can occur, and you need to be prepared for use alternative options in this case.
Okay. Thank you so much. Thank you so much, Mona, for asking the question.
The presentation, if people want to have it, I sent to you and you can share with everybody.
Yes. And if anyone else has questions, you can just send it to us. I'll type my email and then I'll course it through Marco. Thank you so much, Marco. So Marco won't be able to join us for long. So thank you so much for sharing your time and for sharing the very interesting updates on the researches on long-acting ART. So when Marco mentioned earlier, it's very important for us to be part of these discussions. And we are very, like us at GNP Plus, we are very happy, or we will be very happy to provide these platforms where we can interact and share our thoughts and questions on on this ongoing researches. We have the discussion on the new technologies and the researches and new products on long-acting ART. But how do we make sure that when this innovative long-acting antiretrovirals go to the market, how do we make sure that these are accessible, these are affordable, and these are available to the people living with HIV? Now, in the current scenario, we have like the licensing agreements. So we have invited our colleague from the Medicines Patent Pool, Esteban Buroni, to kind of like share with us some thoughts on the NPP VIV licensing agreement on the CABLA, and maybe at some points addition of HIV treatment with RPVLA as a field of use in addition to PrEP, and how do we expand these options to cover private markets? Esteban, over to you. You are on mute.
Thank you so much, Inad, and thank you, Florence, and thank you for the GNP Plus team for giving me the opportunity to say a few words. Yes, I wanted to walk you through some recent developments around access to long-acting HIV medicines, really focusing primarily on the treatment side, because there's been, of course, a lot of focus on the PrEP side, but I think it's critical to also be thinking about what's happening in relation to access on the treatment side. I hope you can see my slides. I'll put them on slide share mode. So I don't have any conflict of interest. I do want to acknowledge our funder. Unitate funds all our work in HIV. It's been a key partner, and really also mention that anything that we're doing at MPP in terms of supporting access is always done in partnership with so many of you and so many of others. And I really want to acknowledge that it's never MPP alone. It's always a huge team effort, and particularly very close work with the communities. Now, in terms of what I wanted to present to you, briefly remind you what MPP is for those of you who are not familiar, because I think it might be interesting so that you understand why we're involved in this and how we operate, and then jumping into long-acting ART and access. What could that look like? And some resources that may be helpful for you going forward. So as a reminder, MPP is a public health organization. We were established back in 2010 by Unitaid, and we work to improve access. And how do we do that? The key thing that we do is we do a voluntary licensing agreements that enable generic products to be made. We also at times support with transferring technology to manufacturers in low and middle income countries. So if you say we do voluntary licensing, I guess a key question I often ask is, so what does that mean, and why do we need voluntary licensing? What does that do? And so just to very briefly give you a sense. So these are some of the key medicines that people are focusing on these days, and both for prevention and for treatment. And then if you look at the patent expiry days, that means that typically you wouldn't see generics coming in until those dates. So you typically, given that new product comes to market, like dolutegravir came to market in 2014, you would typically not see any generics until 2026 at least, and some of the combinations until 2030, 31. And so, but in reality, we've got many generics on the market making dolutegravir, making TLD, making TAF, ED, and many other combinations. Dolutegravir pediatric, abacavir, lamivudine, dolutegravir for children. So how come all of these generics are there, and how come we've had so many price reductions? And this is really because these licenses were put in place in partnership with ViiV Healthcare that has enabled the generics to come in before patent expiry and all that competition to happen. And seeing hopefully a similar thing with cabotegravir coming up soon, and again with lenacapavir as well. In the case of lenacapavir, MPP wasn't directly involved in those licenses. There were agreements that were done directly between Gilead Sciences and generic manufacturers. But again, we're going to see generics significantly before the patent expiry. So that's why licensing can be important. And when MPP becomes involved, of course, we do that from a public health perspective, which is key. And just as a reminder, this is what's been possible with dolutegravir and why that strategy has worked so well. Today, since 2014 and our agreement with ViiV in 2017, 129 countries have had access to generic dolutegravir-based regimens. That's the broadest ever for a access license to date. The cost of DTG-based regimens today, first line, is the lowest it's ever been for a WHO-recommended HIV regimen. It's under $40 per patient per year. And that has been critical to enable such a massive scale-up in the number of people on treatment. And that's over 23 million people we estimate today on generic dolutegravir-based treatment. So really a massive, and of course that's the work of so many people and many of you in the room, all the advocacy that happened, and participation in the various critical structures from the Global Fund to PEPFAR to Unitaid. Of course, Unitaid plays such a key role in many steps of this process in enabling dolutegravir to really be adopted as the preferred first line, and all of that work with the communities at every stage of the way. So how do we work? We're the organization that seeks to put in place these voluntary license agreements, and we negotiate with the innovators, such as patent holders, like ViiV Healthcare, but it can, of course, many others as well. We earlier had, licenses on tenofovir with Gilead, and on atazanavir with BMS, and on lopinavir, ritonavir with AbbVie. So we really have over the years been putting in place. But dolutegravir has been perhaps the single biggest, because it's been also the most recent regimen to be massively scaled up, much faster than used to be the case. This is how the way we operate. I won't go into that, but really identifying which are the key medicines we need to work on. We negotiate with a licensed source or with the innovators. Then we make an open call for proposals so generics can apply and get a license. We then work with the manufacturers to accelerate the development, make sure that the right formulations are developed, such as new pediatric formulations, and then that they get registered and that they get supplied in country, and that competition between manufacturers really helping to bring the price down. Now, in terms of long-acting antiretroviral treatment, These are the current HIV guidelines, of course, massively simplified, and Mark, of course, has explained this much better than I would ever be able to. But just wanted to flag, these are the key. So if you look at your left side, these are the HIV treatment guidelines. You see the key regimens that or drugs that are recommended, and each one of these are being the subject of an MPP license that are enabling more affordable access. Those have a red star are the long-acting options, and then on the right you have those for PrEP, which of course you're also familiar with, from oral PrEP to dapivirine, Cabelet, and lenacapavir. Again, those in red are the ones that are long-acting. So you see how long-acting options are increasingly becoming more and more important in HIV, both PrEP until recently, but since July this year also for treatment. And that was certainly not the only one, but one of the novel features of the new guidelines announced here in the IS was this inclusion of cabotegravir for treatment. And what that meant is firstly that meant that WHO is now recommending a long-acting treatment regimen for the first time, an injectable that's taken every 2 months, includes cabotegravir and rilpivirine. And at the same time as the announcements of that change in recommendations, MPP and ViiV announced that our existing license on cabotegravir, which so far had focused on PrEP, is now expanded also to cover treatment. And the treatment regimen that is part of the WHO recommendations, which is cabotegravir with rilpivirine, and with a geographical coverage of 133 countries. So this is a direct response really to the WHO recommendations. And I also thought I'd include this paper that came out more or less at the same time or shortly after, in case you're interested to read a bit more about the what this means and the importance of getting long-acting HIV therapy. But also acknowledges, and in the paper you also see some of this, many of the challenges that still remain. This is not, the fact that you have a license doesn't mean that it will reach everybody, and so that's really what we need to be focusing in the future. So, as a reminder, what this announcement meant was that the 3 manufacturers that have been working with us until now on cabotegravir, which are Aurobindo, Cipla, and Mylan, are now also be working on treatment. 133 countries, both public and private markets. Previously, some of the private markets were not included. Now we've got both public and private. That could be important in certain markets where perhaps national HIV programs don't cover the entire population. In some countries that may not be relevant because it's all provided by the public sector for free. Of course, we know with the funding cuts, there may be challenges and there may be more people needing to access their ARVs outside of the ARV programs, but hopefully that will be very limited. And of course, also recognizing the different quality assurance mechanisms, we want to make sure that the medicines that get developed by these generics are quality assured and meet all the relevant quality standards. And so recognizing an additional option, which is the WHO listed authority pathway in the recent license. Here are a few more details about the license, but I don't think there's much more to be said than in the previous slide. So I'll carry on. In terms of the countries, we said 133. So this is an overview of that. Essentially, the countries that are explicitly mentioned in the license, and then there's all those that don't have any patents on Cabelet. And so Beatriz had done an analysis of that, which I'm showing this from back in 2022. But if you want to figure out exactly which countries are in purple, you can go and check on MedSpal, because there you can really see, you can put your country, you can put the drug you're interested in and find out, is there a patent or not in your country in relation to that drug? And that means that, there are, those are countries that will also be able to access and so, of course, cabotegravir, as Mark already mentioned, is not the end of the story. There's cabotegravir rilpivirine is the only one that exists today that's approved and that is recommended by WHO, 2-month intramuscular injection with certain challenges. Rilpivirine requires a cold chain, so it's not extremely easy for the supply chain in all circumstances, and intramuscular injection, but really a potentially really important option for certain groups. As you can see, there's other options. Some, in purple, you see, in what is it? pinkish is injectable options, and there are also some oral options, mostly weekly, that are in different stages of development. So as you can see, these are not approved, not ready for, but really coming down the pipeline. And you also have for PrEP similar interesting set of products, including some in the pipeline, including again some oral monthly pill at the bottom. So there's different options that are coming, and really we need to now start working on getting them ready for uptake. Cabotegravir with rilpivirine generic is not available yet. It's under development. The generics have to have completed the development of cabotegravir in terms of the lab work. They now need to do the bioequivalence studies to show that it's equivalent to the innovative product, and that can take time because it's a long-acting regimen. So it will still have a couple of years to go, hopefully a bit less. But that's for cabotegravir, and then you have the combination of cabotegravir with rilpivirine that is also required for treatment. So it will require time. Having said that, I think the sooner we can start preparing the ground, the better. Now, I wanted to conclude simply by flagging an important resource. It's called LAPAL, and it's a hub for long-acting therapeutics information, something that we put together with Unitaid funding and support from many others that you can see here. And it really, you can look, and it's not just HIV related, but a lot of relevant HIV information. What's in it? It's got information on the technical features of a given product, on the development status, on the regulatory state, where is it registered, where isn't it, intellectual property, where is it patented, where it's not, etc. And you get all these different visualizations, maps showing you where something is registered, timelines for different clinical trials and what's going on, etc., etc. So really super useful tool that I would advise everybody to go into. It's lapal.ch. There you see the link, lapal.ch, or the QR code, because it's a good way to find out what's going on. And in terms of patents, if you want to find out more, as I was saying, MedSpal, what is patented where, I would recommend that. And for those of you that will be at ICASA coming up later this year, we're looking at having a satellite session. It's going to focus on long-acting HIV medicines, most probably on the treatment side, because I think it's been less perhaps focus on that. So of course, that's what we're working on right now, and looking forward to seeing some of you. I won't be there, but colleagues will be there and will be available to discuss. Thank you so much for that. And maybe just to conclude, licensing has played a critical role in access to innovative ARVs. We've seen that with dolutegravir and TLD in the past, also with other drugs. Before that, in July, WHO made its first long-acting treatment regimen recommendation. That's for Cab-LA with rilpivirine. At the same time, MBP and ViiV announced a license on this regimen that will enable generics to come to market. Now, there are still multiple challenges to roll out long-acting regimens in LMICs, and I know we're going to be talking about service delivery after this, so it'll be good to be thinking also how we're going to do that in terms of service delivery. And there are other long-acting ARVs in the pipeline, and some of those may have different modes of administration. And LAPAL really is a key resource that I would recommend for finding out more about long-acting medicines for HIV and beyond. Thank you so much for your time.
Thank you so much, Esteban. I have a question. Just for our participants to understand. Would you I'd like to clarify what do we mean when we say licensing countries versus what do we mean when we say country that does not have a patent?
Sure. So when we negotiate a license, the text of the license is public, and so everybody can see it on our website. And there you will see a list of countries that are mentioned. Yeah. So in the case of the cabotegravir license, I think it's about 90 countries that are mentioned, or I may be, I can't remember the exact number, but there's a certain number of countries that are mentioned explicitly in the license. But then you have a provision that says that you also be able, the generics will also be able to supply generics in countries where it's not patented, beyond those 90 countries. And that's where it becomes relevant to look at these things. So you would have seen the press release from MPP and ViiV made it clear we're talking about 133 countries. Those are the countries that are going to be able to benefit. It's not just the 90. And so that's why, I like to make that explicit. But for all practical purposes, it doesn't make a huge difference. It doesn't make any difference really. Like it's the same happened with dolutegravir and TLD, and many of those countries, or those additional countries without patents, they've been able to access generic dolutegravir and TLD. So it doesn't make any real practical difference. It's just important to flag it because people, when they go and look at the license, might say, "Oh wait, I don't see my country listed here, but I was told that I could get generic." And so it's important to understand why that's the case. So that's why I thought it was important to mention that. Thank you.
No, thank you. Thank you for clarifying that, because I think that's very important for us to understand. If we are going to advocate and we're going to be visible, having this advocacy to make the long-acting ARTs or the ARTs accessible or affordable at the country level, I think that we people living with HIV should understand the concept. But thank you so much. I encourage everyone to chat in your questions in the Q&A chat box. Esteban will be staying with us in the next few minutes. If you want to ask questions, we will have Q&A later. We just had a special Q&A session for Marco because he won't be staying. He won't be staying with us for the rest of the for the convening. Thank you so much, Marco. I'd like to introduce the next presenter. I have worked with her as well in the previously, and he's another community champion that I can say. I'd like to call Anna. You have the microphone for the differentiated service delivery. Thank you.
Great, thanks so much, Inad. So I really want to thank GNP Plus for the opportunity to talk today. They have given me some very long questions that they want me to cover in these 10 minutes. So I'm going to do my absolute best. But I just wanted to pick up on something that Esteban said and say that in this presentation, I'm not focusing a lot on what we think about regarding long-acting and differentiated service delivery, but I would welcome the opportunity to discuss this with all of you in the future, because I think we are thinking about how to build for the future. So for those of you who don't know, this is our definition of differentiated service delivery, being that it's a person-centered approach that simplifies and adapts services across the cascade to both reflect preferences and expectations of groups of people, while also reducing reducing burden on the healthcare system. And when we think about service delivery, we think about these building blocks or these W's. So we think about when, where, who, and what. And in the context of antiretroviral therapy, we think about a set of building blocks for ART refills, a set of building blocks for clinical consultations, and a set of building blocks for psychosocial support. And the reason I want to draw that out a little bit is to say you might have a different person that you see for your clinical consultation, then that might happen at a different frequency in a different location than when you might get your refills. And so we want to make sure that we're kind of keeping this idea of separation of the clinical consultations from the refills as different concepts. We talk about 4 different models of DSD for HIV treatment. On the top, you've got group models, and on the bottom, you've got individual models. So you can have group models that take place that are facilitated by a healthcare provider, or group models that are facilitated by peers. So those would be the 2 types. And then individual models, you might have some that are at health facilities and some that are outside of health facilities. And again, those ones outside of the health facilities, there's lots of different types of these. So those could be outreach vans, they could be models at community-based organizations being run by key population-led networks, they could be collection points in private pharmacies. So just to say that there's a diversity of models that we fit into these 4 buckets. We also are going to talk a little bit about multi-month dispensing, and that's not a model in and of itself. That's just talking about the duration of the treatment refill, and that is different than multi-month scripting, which would be the length of your prescription. And again, just at the bottom here, I've said that these clinical consultations we want to consider separately, or that in all the models, again, you've got a set of building blocks for the clinical consultations and a set of building blocks for the ART refills. So that's the quick, what is DSD? Now, the first question that I had from GNP Plus was to talk about how the people living with HIV leadership could better respond to and support models that reduce stigma, criminalization, and systematic exclusion. And while I think this is a really important question, I think I'm absolutely the wrong person to answer this. And I think that all of you, as the people living with HIV leaders, are best placed. And so I, of course, very cheekily went and stole this screenshot And I'm not sure if any of you can immediately recognize who this is from or who wrote this, but this was a quote from a paper that Florence wrote with your other co-executive director and other colleagues back in 2023. So again, I just want to say that DSD is person-centered, and Florence also spoke about having people living with HIV at the center. So you're going to be all of you in your leadership that is going to have much more experience, much more insight, and much more skill transfer on how to support people living with HIV to be at the center. The rest of us are really here to be allies. And so I hope we can discuss that as a collective later. The second question was around acknowledging that people living with HIV have multiple health needs, that HIV may not be the only condition. And so how does DSD fit when we think about integration? Integration about mental health, hypertension, diabetes, etc. I wanted to highlight different guidelines than Marco mentioned, highlight the recently updated service delivery guidelines from the WHO. And here these have two new or two updated recommendations that are relevant to this question. On the top, you'll see that diabetes and hypertension care should be integrated with HIV services is an updated recommendation. And secondly, that mental health care for depression, anxiety, and alcohol use disorders should be integrated with HIV services. So I just want to say that it's also WHO that's recommending this, and it's kind of all of our collective responsibility to support its rapid implementation. As mentioned in the intro, I'm based in South Africa, and in South Africa for a long time, we've had a non-verticalized HIV program, meaning that HIV is within our chronic care and TB are all part of one package. And in South Africa, our differentiated service delivery models include facility pickup points, as well as external pickup points from CBOs and private pharmacies and adherence clubs. And in these DSD models, you can be living with HIV, you can be living with HIV and other chronic conditions, or you can be living with a chronic condition. So in red here, you'll see that of the 3.7 million people who are in a DSD model in South Africa, 60% are getting just their HIV treatment in this model. Another 17% are living with HIV in another chronic condition, and they get their refills through the same mechanism. And then in purple, you can see that the 23% of the people in a DSD model are not living with HIV, but are living with another chronic condition and still picking up their medication in this way. And so what I want to highlight here is two things. The first is that in that blue color, DSD models can be integrated for people who are living with HIV and other chronic conditions. And then also in the purple, that DSD is not just about HIV. DSD models also can potentially have a role for other chronic disease or other prevention services. And so there are examples of how this is being done. And therefore, we should maybe really update our definition of DSD to say that it's about simplifying and adapting health services across the cascade, right? This is not just for people living with HIV. We can use it for prevention. We can use it for NCDs. We can use it for SRH services. And so let's acknowledge that DSD is bigger than HIV. When we look at DSD in chronic conditions, though, this is an example around hypertension, where we want to make sure that at entry into a DSD model for somebody living with HIV, they are having screening for cardiovascular diseases. And at clinical visits, there's also an assessment beyond HIV. And so I hope for those of you on the call that that is happening, that clinical consultations are not limited just to HIV, but are looking at more healthcare holistically. The other thing that we see, and this is an example in Nigeria, is just like how for DSD, we talk about clinically established on treatment or people who are clinically well, you can do the same for other chronic conditions. So here, this is an example for defining established on treatment for somebody who has hypertension, and it has the same sort of criteria that we see for HIV. They need to be on treatment for at least 6 months. Their hypertension needs to be controlled. They need to have no other acute illness, and they need to have a demonstration of good adherence. And these are all analogous to HIV, right? Where we generally want someone to be virally suppressed, want them to have been on treatment for at least kind of 3 months, want to make sure they have no other acute conditions before we recommend seeing them less frequently for clinical consultations. And what this means is that once somebody is established on treatment, we can separate their clinical visit from their refill visit, right? So maybe we can see them once a year for a clinical consultation, but they could get three-month refills at another community pickup point, for example. And this is the same, could be the same for hypertension, could be the same for diabetes. Also, that refill visit doesn't need to be with a clinician, right? If you have a long enough script, you can get your refill from a non-clinical provider, including from a peer. But what's critical and what we really need to continue emphasizing is this is all provided that the person has enough information, has enough understanding, and is able to self-manage in between those clinical visits, right? So we want to be sure that if we're telling someone they don't need to come back for 6 or 12 months, they know what signs or symptoms to look out for, and that they should present at health facilities should they be having any challenges before their clinical appointment date. Just like WHO has recommendations for HIV, they have them for other health conditions. I'm sure you're aware of this. And so here you can see that for hypertension in 2021, they almost had DSD guidelines. So they said that you could be seen every 3 to 6 months if you were doing well living with hypertension, and that you could be supported by a non-physician professional in between those visits. So there are opportunities for better integration. So just to recap this section, would be that we often hear that people can't get multiple months of treatment refills for hypertension or diabetes, but that's okay, right? That just means you don't need to see a clinician every time. Maybe you need to get a refill every month or 2 months, but it shouldn't be required for you to come to see a clinician if you're doing well. And in many countries, this is where DSD actually started, was saying that we shouldn't have to come back all the time if we're doing well, we could collect our refills. And just a reminder that it's inefficient for both the client and the health system if things aren't integrated, right? If someone needs to come every month to collect their oral contraceptive pills, but they only need to be seen every 6 months for their HIV, that's not helping the client and it's not helping the system. So we've got to become better at integrating. And then my final question was this idea that how is DSD going to adapt as people living with HIV age? What are we thinking about in terms of chronic conditions, mobility, and long-term care? So the first is just a flag. We know we need supports to transition between models. Many of you will think that will be familiar with all the work that's been done to transition to support adolescents as they move to adulthood, right? And so we've got guidance. I've got 2 examples here from Zimbabwe of supporting adolescents to become part of adult clubs. The other example from Zimbabwe on this is around migration. And so for mobility in Zimbabwe, you can get a longer refill, and you can also become part of this other model, the Omalicha model, where you can nominate a family member to collect your treatment on your behalf in your absence and actually post your treatment to you. And so this is just to highlight that this flexibility is really needed to support adherence. As you mentioned, people living with HIV are aging, and this is a great thing. This means that we're extending life expectancy. And here you can see that by the end of 2021, already more than 1/5 of people living with HIV were over 50. And so we need to start thinking about how do we support people who are aging. This could be for comorbid conditions, like we've talked about, diabetes or hypertension, but it could also be for other things that come with aging, frailty, cognitive impairment, mental health conditions. So these are definitely things that we should be looking at. Last but not least, and I hesitated to put this at the end instead of at the beginning, is this idea that we are in 2025, right? I could have told you all of that last year, but we live here now, and we live in a resource-constrained time of great disruption for many of us. And I want to talk about how just important it is that we build on DSD as opposed to dismantling it in these funding moments. We released a new supplement of the journal at the IS conference in July, and this was our editorial, and it had these 4 questions that are relevant at this time. And this is kind of my plea or call to action to all of you. The first is to support countries to embed DSD within primary care. As we've talked about today, it's not just about HIV. We need these DSD systems for other health conditions as well. Secondly, we've seen that with funding cuts, it's often community cadres that are reduced. It's often out of facility models that are cut. It's often community networks that have reduced funding. And so what is the future of these out of facility models? And how do we make sure that we advocate for these to be sustained for how critical they are for HIV and for other healthcare needs. The third in orange, and we can talk about this at another stage, is DSD going to be part of PrEP delivery going forward? We see some examples of this, particularly innovations in the Asia Pacific region, but we've been slow to scale up PrEP, and we need a DSD approach for PrEP now more than ever. And then last but not least, as I started with, how are we going to think about differentiated service delivery with future innovations in drug delivery? How are we going to support self-injectables, longer acting, etc.? And so I hope we can talk about this. So just in closing, please let's not dismantle this thing now. It's always harder to build something up, very easy to burn something down. And so I would just hope that we can work together to keep this in place. And this is my acknowledgement slides. Sorry for speaking so fast. Thanks again for the opportunity.
Thank you so much, Anna, and thank you for addressing the questions. I appreciate that the responses to the questions are really based on not only the real life work, but also based on the real life experiences of people living with HIV. And I think across all countries, people living with HIV are still having problems in accessing treatment. In some countries in Asia and the Pacific, I would say Philippines, like I think that was last year, 2 years ago, where people living with HIV are only provided 7 pills. And they have to go to the clinic every week. And that's not the model that we would like to see. The other convening, we had UNAIDS. We had a very wonderful conversation on sustainability and funding and prioritization. And I think it's very good to have these conversations together. How do we ensure sustainability, integration, reprioritization, and now the community-led differentiated service delivery are still intact when it comes to the upcoming I would say, well, it's an integration, but I would say it's a reshuffle of the HIV programs at the country level. And I think it's very important that you have addressed that people living with HIV should be at the center and should lead. We are the leaders of the response. Thank you so much, Anna. Now, from the guidelines. And from Marco to Esteban to Anna, there are guidelines that have been presented. But guidelines are very good to look at paper. But how do we actually translate these guidelines and this science and researches into practice? And we have invited one of our colleagues from Morocco, from the MENA region, Dr. Rilani, to give us some pointers on how we can make sure that we are translating guidelines to groundwork and practice to be meaningfully translated at the country level, especially where their environment have very prevalent stigma, discrimination, or criminalization. Good afternoon, Dr. Villani. He will be speaking in French. So if we can, for English speakers, if we can switch our language to English. Dr. Villani?
Merci, cher Inad. Bonjour, chers collègues.
Inad.
It's a great
Good
pleasure
morning,
to
dear colleagues.
participate to this meeting organized by PLHIV. I will speak in French. Okay, sorry. C'est un grand plaisir de participer avec vous à
It is
cette
my
conférence
pleasure to
organisée par
participate
ce
with
groupe.
you
Est-ce que je
to
vous
this
remercie
conference
de
organized.
l'invitation et pour contribuer à la question relative aux guidelines de l'OMS et de voir comment les intégrer, comment les mettre en œuvre en pratique. Mon nom est Monsieur Hossein El Rilani, je suis le directeur de l'ONU-SIDA Maroc et je vais aborder la question par rapport à notre contexte Middle East and North Africa et je veux donner des exemples du Maroc. Est-ce que vous voyez ma présentation? Do you see my presentation?
Yes.
OK. Donc, comme ça a été introduit par le collègue, le sujet qui nous rassemble aujourd'hui, c'est comment intégrer, comment mettre en œuvre les guidelines de l'OMS. Et c'est une question qui tombe à point nommé parce que les directives viennent de sortir, d'être publiées. Et ces lignes directrices ne se limitent pas au traitement, mais elles abordent la question dans un modèle plus large et qui redéfinissent un peu le modèle de soins autour des principes simples et révolutionnaires comme le VIH doit être traité comme une conditions chroniques nécessitant un soin intégré, continu et centré sur les personnes. On m'a demandé de traiter 3 points. Le premier, c'est comment traduire concrètement les directives de l'OMS pour leur mise en œuvre dans un contexte où il y a une forte stigmatisation et discrimination et criminalisation des personnes vivant avec le VIH. Le deuxième point, c'est comment les réseaux des personnes vivant avec le VIH et les prestataires intègrent la question de la santé mentale et les maladies chroniques. Et aussi, quelles sont les approches développées pour centrer la santé et les soins sur la personne. Et le dernier point, quels sont les principaux défis pour adopter ces innovations spécifiques, scientifiques, au nouveau modèle des soins ARV et comment la communauté peut-elle être le moteur de cette application et cette innovation sur le terrain. Juste un petit rappel, la région MENA, elle comporte 24 pays, à peu près 456 millions de personnes, et la majorité se trouve l'Afrique du Nord et aussi le Moyen-Orient. Un des grands défis de cette région, c'est les conflits. Il y a plusieurs conflits, il y a plusieurs personnes déplacées et aussi un système de santé parfois défaillant, à l'exception de quelques pays comme les pays du Golfe, et une limitation très forte à l'accès dans certains pays, à l'accès aux soins, et particulièrement pour les personnes vivant avec le VIH. Et un élément aussi très important, c'est la question de la stigmatisation et discrimination qui reste très élevée, et aussi la criminalisation dans ces pays de la région MENA. Rapidement, je vais vous présenter quelques chiffres du dernier rapport de l'ONU-SIDA qui présente un peu l'état des lieux de VIH à l'échelle mondiale et qui a été dénommé « Où sommes-nous actuellement? Quel est l'état des lieux par rapport au VIH-SIDA ?» Donc, comme vous le savez, il y a environ 40 millions de personnes vivant avec le VIH, dont 1,4 million d'enfants, et 53% sont des femmes. Les régions les plus touchées restent toujours les mêmes, c'est Eastern and Southern Africa, Western and Central Africa et l'Asie-Pacifique. Et les nouvelles infections, je dirais, heureusement, la riposte mondiale a réussi à baisser les nouvelles infections. Et ça se traduit dans ce graphique. On voit un peu les pays qui ont réussi, qui ont ouvert à réduire les nouvelles infections. Par contre, 3 régions, dont la région MENA, continuent à avoir une accélération des nouvelles infections, surtout la région Middle East and North Africa, avec 2 autres régions qui sont le Latino-América and Eastern Europe and Central Asia. En ce qui concerne les décès, le schéma est un peu différent. Bon, en tout cas, la majorité des pays, les régions ont réussi à baisser les décès. La seule région où il y a toujours un petit problème, c'est la région de Eastern Europe and Central Africa, avec une moyenne de 630 000 décès par an, c'est ce qui représente à peu près un décès par minute. Pour les traitements, il y a toujours un manque et un déficit. Il y a 9 millions de personnes qui reçoivent les traitements. Il y a quand même un déficit qui ne reçoivent plutôt pas les traitements par rapport aux 30 millions de personnes qui reçoivent. Donc, il y a 3 régions qui sont touchées par ce gap et qui sont l'Eastern and Southern Africa, Western and Central Africa et de l'Asie-Pacifique, où l'accès au traitement continue à poser problème. Des modèles d'impact, comme ça a été présenté par mes collègues précédemment, l'impact des coupures financières risque de donner lieu à une augmentation des nouvelles infections et aussi augmentation des décès. Et ça, on le sait, l'impact sur l'accès au traitement va poser un grand problème pour les personnes vivant avec le VIH, particulièrement dans les régions les plus touchées par le VIH. Globalement, la cascade, je ne veux pas aller dans le détail, mais juste pour dire que notre région est l'une des régions où la cascade reste quand même faible, particulièrement l'accès au traitement, à peine nous sommes à 74%. Donc, je reviens aux 3 questions qui m'ont été posées et comment traduire les lignes directives de l'OMS dans le contexte MENA, sciences, droits et humains. Et La première réponse, c'est comment transformer les recommandations en politique inclusive. Elle est très importante pour traduire les recommandations, ou le guideline de l'OMS, que ces directives doivent être traduites par la politique nationale. Intégrer les soins du VIH, du diabète, l'hypertension, de la santé mentale et les autres maladies non transmissibles dans les programmes VIH. C'est très important. Et pour arriver à cette approche d'intégration pratique, c'est renforcer le cadre juridique des pays, protéger la confidentialité, interdire le refus de soins, adopter les directives nationales sur la non-discrimination dans les structures sanitaires et aussi mettre en œuvre des réformes administratives programmatiques pour pouvoir intégrer ces guidelines pour qu'ils puissent apporter les soins nécessaires centrés sur la personne et plus large, c'est-à-dire ne pas faire un focus sur le VIH, mais comme vous le savez, la population des personnes VIH vieillissent et les besoins de traitement d'autres maladies chroniques comme l'hypertension et aussi la santé mentale nécessitent aussi une intégration. Et bien sûr, aligner les politiques nationales sur une approche basée sur les personnes et aussi la non-discrimination et la non-stigmatisation et l'équité d'accès aux populations. Aussi, la question très importante, le VIH-Sida est resté plusieurs années indépendant, je dirais, isolé des autres maladies, alors qu'on peut la considérer comme une maladie chronique et qui peut intégrer le circuit des maladies chroniques et avoir d'autres services avec le VIH qui peuvent répondre aux besoins de personnes vivant avec le VIH. Comme je viens de le dire, la population des personnes commence à devenir de plus en plus âgée et d'autres besoins de santé apparaissent. Et les données de l'OMS montrent que jusqu'à 25% des personnes vivant avec le VIH souffrent d'hypertension et près de 10% de diabète. Et les effets métaboliques de certains traitements et les inégalités sociales aggravent cette situation. Donc, l'intégration des soins avec les maladies non transmissibles, avec un système vertical séparé, apporte des grands bénéfices, notamment un meilleur contrôle des tensions artérielles, du diabète, la réduction du coût des traitements, la diminution de la stigmatisation et la discrimination, parce que les personnes vont se rendre dans un service qui offre des services généraux. Donc, on ne va pas étiqueter les services. Service VIH-Sida, c'est très stigmatisant, alors que ça va être des services généraux. Et aussi un gain en efficacité pour les systèmes de santé. Et des études ont montré que cette intégration peut réduire le coût total de prise en charge entre 35 et 50% d'une manière générale pour une personne vivant avec le VIH. Et bien sûr, bâtir sur les systèmes de santé, ce qui a été démontré que absolument il faut que baser les soins des personnes, surtout dans les pays sur les soins de santé de base, c'est-à-dire offerts par le système de santé, parce que c'est ce qui va permettre une large couverture. Et avec l'intégration, il y aura plus ce souci disons, de stigmatisation, discrimination et confidentialité que pose la question de VIH-Sida. La question de la santé mentale, et toutes les études ont montré que 30% des personnes vivant avec le VIH souffrent de problèmes de montée mentale, et c'est quelque chose qui doit absolument être intégré dans le soin des personnes vivant avec le VIH. Et ça permet de résoudre pas mal de problèmes parce que ce qui a été démontré que la dépression multiplie par 2 le risque de non-observance thérapeutique et réduit la signification et la probabilité de suppression virale. Donc, c'est une question critique très importante parce que comme ça a été démontré par des études que 30% de personnes vivant avec le VIH à cause de la dépression, à cause des problèmes de santé mentaux, risquent de ne plus adhérer au traitement. Et ça pose un problème pour la rétention et le soin, la suppression de la charge virale et aussi pour la qualité de vie de ces personnes. Dans notre région MENA, comme vous le savez, caractérisée par une forte stigmatisation et discrimination des personnes vivant avec le VIH et la question du VIH-Sida. Parler de la santé mentale reste délicat aussi, et c'est justement là que réside notre responsabilité. C'est former les prestataires à la reconnaissance des signes de détresse psychologique, collaborer avec les réseaux des personnes vivant avec le VIH parce que c'est là où la communauté joue un rôle très important, et aussi de confidentialité et de continuité de soins. Lier les soins VIH au service de santé mentale primaire, conformément aux recommandations de directives de l'OMS, Et bien sûr, l'OMS a démontré que ce modèle basé sur le partage entre médecins, infirmiers, pairs et aussi la communauté permettent d'apporter beaucoup de bien et aident les personnes vivant avec le VIH d'intégrer et de suivre le traitement et d'atteindre la suppression de la charge virale. Un autre élément très important, c'est soutenir l'adhérence. Et le moteur de succès de l'adhérence, c'est bien sûr, c'est la communauté et qui joue un rôle très important. Et ça a été démontré avec plusieurs. C'est pas quelque chose de nouveau, mais c'est quelque chose qui a été démontré que la communauté des personnes vivant avec le VIH apporte un soutien important pour l'adhérence. Et sans l'adhérence, il n'y a pas de traitement durable. Les lignes directrices de l'OMS confirment 4 interventions qui ont un fort impact. C'est le counseling et l'accompagnement personnalisé, le système de rappel, les SMS, les applications, les visites, généralement apportés par la communauté, le soutien par les pairs et navigation communautaire, et bien sûr l'éducation thérapeutique, un élément clé de suivi des personnes vivant avec le VIH. Ces approches combinées à la dispensation mensuelle et à la télémédecine sont particulièrement adoptées dans nos contextes. Je cite particulièrement le Code du Maroc qui a introduit les modèles différenciés, la dispensation multi-mois et aussi le suivi par les éducateurs pairs. Ça a permis d'améliorer notamment, disons, la santé des personnes vivant avec le VIH. Bien sûr, il reste des défis qu'il faut surmonter. Et ce guideline va nous aider à renforcer notre système d'intégration et aussi de renforcement de la prise en charge des personnes vivant avec le VIH. Bien sûr, la question de communauté, elle est centrale et les lignes directrices de l'OMS rappellent que la participation communautaire n'est pas un plus, mais c'est un pilier de la durabilité, la susceptibilité des ripostes. Et dans la région MENA, les réseaux des personnes vivant avec le VIH, les associations de lutte contre le sida, les groupes de soutien, les ONG communautaires doivent être financés et contractualisés. C'est l'élément clé. Si ces communautés ne reçoivent plus le moyen financier, ça risque de faire disparaître un rôle très important, particulièrement dans notre contexte où il y a moins de moyens financiers. Bien sûr, impliquer les communautés dans la surveillance communautaire et le lead monitoring, et bien sûr, à les associer dans la conception des modèles de soins. Et la communauté savent où se trouvent les obstacles, la peur, la honte, la violence, la pauvreté, la rupture de traitement, les impliquer et c'est reconnaître leur expertise et c'est qui transforme les lignes directrices en pratiques durables. Je cite un exemple pratique au Maroc, c'est au moment de séisme où la communauté a joué un rôle très important pour acheminer les médicaments aux personnes qui ont été touchées par le séisme dans la région de l'Haouz au Maroc. Donc, en résumé, il y a 5 actions prioritaires pour la région MENA. Institutionnaliser l'intégration des soins dans la santé mentale et les maladies non transmissibles. Former et soutenir les prestataires non médecins, les pairs, les infirmiers, la communauté, selon le principe de task sharing. Mettre en place des tableaux de bord pour suivre la dignité et pour la suppression de la stigmatisation et de discrimination. Financer les réseaux communautaires et bien sûr créer des plateformes numériques régionales pour le rappel, le suivi, la télémédecine et le partage des données anonymes. Les lignes directrices de l'OMS nous demandent pas seulement de soigner mieux, mais elles nous demandent de soigner autrement dans un contexte MENA marqué par la stigmatisation, les inégalités et parfois la peur. Transformer la pratique médicale en acte de dignité devient une mission de santé. Et dans cette région du monde riche d'humanité et de spiritualité, nous pouvons bâtir un modèle où la science soigne, la communauté soutient et l'indignité guérit les personnes. Et merci pour votre attention. À vous, Inam.
Thank you so much, Dr. Rilani, and thank you for sharing the context of the
Merci
MENA
beaucoup,
region,
Dr.
which I think is a very,
Hossein, pour avoir
very
partagé ces éléments sur votre
timely
contexte.
in terms of
Et
the
cela
discussions
tombe à
on
point
stigma
nommé
discrimination.
en ce qui
Thank you also
concerne
for mentioning
la
about
lutte
the context
contre la
of
discrimination.
conflict.
Merci aussi
And
d'avoir
I
parlé
think
des conflits
that one of the challenges in making sure that these guidelines are actually practiced are in the settings of the humanitarian crisis and conflict, and making sure that all other services such as the mental health services and other health services are integrated into the current program. Thank you so much for sharing the context in the MENA region. You're welcome to stay, Dr. Rilani. So we are now moving forward to the next segment where we are inviting our community leaders, our PLHIV leaders, to share their work at the country level. So we have, sorry, if you can stop sharing your screen. Okay. So no, I'd like to call in. So this is a discussion within our PLHIV community, and we welcome Esteban and Dr. Rilani to stay on for these discussions. So Huzairu from Uganda, you have heard all these presentations from Marco to Esteban to Anna to Dr. Rilani. In your country context, what is the overview of ART service delivery? And what are the challenges, like in providing ART services, what are the challenges that you're currently facing? Sorry, are you not hearing? Did you just hear me? Was I just speaking without without audio? Sorry about that. Can you hear me now?
We hear you.
Oui.
Okay,
We heard
cool.
you.
No, I was asking Huzairu, from all these presentations on the science and the research and the guidelines, we would like to focus now on the country level, on the PLHIV perspectives on the ART services. Huzairu from Uganda, I was asking what is the overview of the ART services at your country, and as a service provider, what are the challenges that you're facing in delivering the services?
Yeah, thank you so much, Inan. The team on the call has been a very wonderful presentation from the first presenter, and I've really heated on some of the issues that I intended to speak to. First of all, my name is Nyanzu Zairu. Team leader, Ginger Network of Younger People Living with HIV in Uganda. We are a community youth-led organization based in Ginger, one of the cities in Uganda. Straight away, I will speak in terms of progress as a country. We are now at 90% coverage. We have a population of roughly 1.4 million people on treatment. In terms of progress towards the 95 targets, we are there, for example, 95% people know their HIV status. We are 80%.
Huzairu, can you speak louder? Can you speak louder?
Can you hear me now?
Yes, okay, thank you.
Yeah. I was saying in terms of enrollment to care, we are at 83%. And in terms of the rate for suppression, we are at 79%. But amidst that, there is a big gap when it comes to children and young people, because even when it comes to diagnosis or knowing the HIV status, we are still low, and it is very worse when it comes to viral load suppression, which is below 80% at 72%. This worries me so much. The other thing, Anna spoke about DSD. As a country, the DSD has worked to support like at groups, mathematics, dispensary, fast track refills have improved the retention, okay? But still there is a gap. For example, we know very much, everyone has been speaking about it. When we had the fund cutting, we were caught by surprise, and the government has been struggling to to integrate the services. And we have seen many of our young people who are supporting at the health facilities that have been laid off. And we have seen staffs from the government who have not had experiences of working with PLHIV coming in to take up roles, which is still a challenge and a big gap in terms of administering, in terms of managing. And you see, we still anticipate the drop, still even in retention, even in suppression, we still anticipate. However, that does not take away some of the things that we have. Yes, for example, the EMTCT is doing. People are saying I'm not audible.
Huh?
Am I clear?
Yes, you can. You're clear. Yes.
Yeah,
You can speak closer to the microphone. Yeah.
Okay, I was saying that does not take away some of the good things that we have seen. For example, as a country, we are doing very, very well when it comes to EMTCT. It has contributed greatly to reduction of new infections, mostly among the children. But also, despite these gains, challenges still persist, mostly around linkage to care, adherence, and then integration of psychosocial support, and then addressing the needs of young people, especially the key populations. Excuse me. Why am I speaking about this in particular? As a country, we have laws that are restrictive, especially when it comes to key population. And this has been exacerbated by, when they passed a law to prohibit or to limit access to, prevention services to only specific categories of groups. For example, in our country, it is limited only to the mothers, the intending mothers. This is causing a more gap that need to be addressed. Then when we talk about dependence on donors, it has created a problem. Actually, when we were doing after the fund cut, we were doing a big analysis on our government contribution to HIV, and we only realized the government was only contributing 14%, which literally is a big gap. But to close it in a short period of time, it takes a lot of struggles. And more importantly, a country like Uganda that is still struggling. So here is, you see, the gap is really what? But again, something that will save us again is under limitation. That will be the prevention. Actually, for me as a person and as young people, most of us, we do believe as a country like Uganda, we cannot have the resources to support over 45 million people on ERT, but we can support people to access the prevention options. But again, this is not working out. Then when it comes to, provision of psychosocial support and mental health, like energy asked in one of the questions, how can we integrate? Now with the deep integration, people who have been supporting in offering psychosocial support have been laid off. And you find some of these health clinics are high volume facilities. You find the nurse or a clinician seeing over 100 people, specific only for HIV. He has not seen other people from other diseases who have come to the facility. It is really hard to have some of these things, and yet they're very much important. Then we continue to experience also stockouts, commodity stockouts. And sometimes this is as a result of poor planning by some of the people at the facilities. But even sometimes it's at a national level where there's a time we missed out on third line for almost a month. And we were wondering what were our people taking during that period of time. So this is still also a gap that is, constraining us. Then also, I'll speak to, of course, to retention to care and adherence gaps, because this program was cut out that was supporting some of these programs. It is hard sometimes to, I saw Anna speaking about long distances and people traveling long hours to access services. Yeah, but some of the programs were really supportive. Even when we talk about the ESD model, some of the people who were supporting using some of the people who were supporting using the ESD model have been laid off. People who want to support and do the sick lads, the community, they are not there. They are no longer facilitated. You see, the program is crumbled. And also, the other key issue that has really affected is the slow delivery of the information, the sensitization and awareness about with all these changes is very, very minimal when it comes to the community level. Unlike the days when HIV was still at the peak, where we used to see posters, we used to see adverts, TV. Today, these are not there. You find they are taking the in-charges in the high-level meetings. They go and see high-level meetings, and the delivery of this message, it ends in between there. It does not reach the last person on the ground, So that is also affecting. If information was on the ground, people actually know and actually adjust and actually think what's happening. But information is not there.
Yeah.
Then the other thing that I wanted to do is this is general to African countries. We are importing ARVs from that at a very high cost from other countries, and we are not supporting local manufacturers to produce ARVs locally. I don't know what is the gist behind, but we need to really look at into local investments to save, because I don't really understand whether it costs the country to support local investors to make some of these things locally at a reduced cost than, importing from other countries. However, that side, this is what we have done and what we're trying to do as a to try to address or to fix some of these issues that we're experiencing. As a network, we are embracing a model called the Village Savings and Loan Associations, where we are mobilizing our young people in their communities. The idea behind it is that they are coming to save. That is okay, the main idea. But for us, we are using it as a mobilization tool. As they come to save, we are able to offer the psychosocial support. We are able to offer the information on ADCD. We are able to offer support. Some of them are experiencing mental health issues. We are able to give most of the information. The other thing we are doing is we are doing the DOTS, the directed intervention therapy. We are supporting our young people to take education. Those who are not adhering, we are reaching out to most of these high volume facilities to do the line list and go and support them. The other thing we are doing, we are still using drama. This has been around, but we are taking the new turn around it to use it to provide psychosocial support still again to our young people, but also to use it for peer-to-peer support. The other thing
Josairu,
yes,
I'd like to ask you to wrap up now.
I'm wrapping up. I know
Okay.
this is the problem. People are giving us last minute. But the other thing,
yeah, I understand.
But as I wrap up, I really want to say is that the future of HIV prevention should be really rooted in the community. We should give an opportunity to the grassroots community to take lead in support fellow peers to take lead in some of these programs. It is really, really key because they know what is affecting them, they know what they need to do to address it. I want to make a call. Young people have organized themselves. Let's support them to address the challenges they're experiencing. Thank you so much, Inad, once again. My name is Nanzi,
Thank you.
Team Leader Ginger Network of Young People Living with HIV. A pleasure to share.
Thank you.
Today.
No, I promise we will put the communities as the first speakers in the next convenings. Thank you so much, Huzairu. I'd like to ask if Andrew would still like to share your work in Malaysia, like very quickly. Otherwise, we can I can Andrew, are you okay?
Yes, I am. Can you hear my voice?
Andrew, are you there?
Yep. Yep, I'm here. Can you hear me?
Yes, I think you can speak now, Andrew.
Okay. Just wanted to share with everybody that there
We
were some
cannot hear you.
ideas. Oh, cannot.
But while waiting for Andrew, thank you so much for the points that you have provided in the Q&A chat box for highlighting the importance of putting in the mental support in HIV services. And Livy, I hope you feel better soon. We agree that there are a number of treatment defaulters in different countries. And thank you for the points, your recommendation in strengthening community-led monitoring and service delivery, and integrate HIV services into general healthcare. But again, the issue on this one is on the stigma and discrimination in order for us to improve the access. Andrew, are you there?
Yes, I am. Can you hear me now? Can you hear me
We still
now?
cannot hear you.
Oh dear. Okay. Something is wrong. I've unmuted already, but the thing is that I don't seem to be heard.
No, we can hear you. I can hear. We can hear.
Oh,
we can hear. Okay.
Yes, thank you.
okay. Am I
Okay,
in the
go.
right channel? Okay. Just wanted to share with some of our colleagues across the world that there is a toolkit that we have been using in Malaysia. And basically, this is for a very simplified way of explaining to our clients, usually people who are newly diagnosed, or usually people who come back after defaulting treatment. So it helps them understand the reason why they're taking the medication. So it's a very simplified, almost kindergarten-like show and tell. For us, we just call it HIV 101 for the clients. Inad, would you like to share some of the photographs? So it's actually a very simple show and tell, posters on the wall. So we explain to the clients what is their representation of their CD4, the virus coming into the system, and that's where we take the opportunity to talk about the different modes of infection, to cover, the myths and the facts of infection. And we talk about this is also the time that we talk about PrEP, and we talk about PEP as well, and emphasize the 72 hours in terms of the prevention for PEP. Then this first slide actually talks about how the virus enters the system, then it fuses into the system, it does reverse transcription, and after that, the integration. I think the next one will be integration. Can you move forward, Inette, for the next one? Yes, okay, the integration, and then the protease is the next one, plus the budding, where the CD4, after being compromised, produces new virus. So it's a very simplified way of presenting to people. And this idea is actually very useful when you go out into the rural areas where you don't have electricity. So you can go to any meeting area, put some nails on the wall, hang up the poster, and just do a presentation. So it's very low tech, it's very simplified, and then it creates a room for discussion where the people understand what the virus is doing in the body. Then the next step after that, if you go back to the third picture, so then we take the same idea and we explain to them how to prevent the viral replication. So what medications work in which areas to prevent the virus from taking over the CD4 and creates this idea, what is the benefit of them taking the medication and why they need to take it every day. So it creates this idea that that it gives them an idea for adherence and compliance, a reason for adherence and compliance. And then this can be adapted based on once the facilitator learns the presentation in its style and presentation, the facilitator can present it in any language. So over here in Malaysia, we present it in English, we present it in Bahasa Malaysia, and we also present it in Cantonese and other languages. So the whole idea is once the person is trained, the delivery can be in any language. So there is no barrier in ensuring that the community is empowered with the information. Then the next one at the bottom, I think the seventh one shows the seventh one after this range. Okay, so this one gives you an example of what it looks like when the whole presentation is complete. So when people take a look at it, we encourage them to take photographs so that what happens is that they will always have a reference in their handphones so that they can always be reminded what is going on in the body, and it gives them an encouragement. So it gives them control over their health outcomes as well. And then the rest of it is the rest of the photographs actually shows some of the other countries which have learned the module and have implemented it in the other countries. So this one was something that I did in Malaysia. The next one was in Bangkok, and after that was in Bangladesh, and after that was in Nepal. And then the next one after that is actually a game that shows adherence and compliance. It's like a simple Jenga block game, and the more times you miss your dose, the more blocks go missing. And so how long does it take before the Jenga blocks that represent the immune system collapses? Things like that. And then the other photographs also show different modules in terms of what happens with the body and what medications. So it's a lot of storytelling as well. And then the final two photographs actually show a little game that we call body mapping. So if the people decide not to take the medication, what are the possible opportunistic infections that could affect your body? So they will draw, and then we will explain to them what is CMV, what is viral meningitis, where does it attack you, what is PCP, pneumonia, and things like that. So it becomes a show and tell. So this can be presented as a complete workshop for a few days, or it can be broken down into individual modules for your monthly support group meetings. So every month you have a different topic, you have a different module. So it creates awareness and understanding and empowerment among the community over a period of time. So what happens is that they get to share with their friends, and then it can be, you get more people trained on this. And then so the idea is it's a thought starter for everyone here to see whether this would be something interesting to focus on. Thank you very much.
Thank you, Andrew. And I think some people has already expressed their interest. They want you to share the module with them, if that's all possible. I can link you. They have sent their email addresses in the chat box, Andrew. So yeah, feel free to contact Andrew. And if Andrew can also put your email address in the chat box. This has been a very long but very informative convening. From, we have discussed from the research, the current research, to licensing, to differentiated service delivery, to country experiences and to the challenges, real life challenges and real life work of our PLHIV networks. This has been very, very informative, and I hope we are not having an information overload. So you feel free to reach out to everyone and to us. And I think the next challenging question is, what do we need to do after this? How do we organize ourselves to make sure that we are not reacting, but we are actively responding to the changes of the times? So with that, Florence, would you like to say something to close?
Indeed. Thank you so much. This has been full of information, and I do believe that most of these meetings, some of them will be an opportunity from which we communities speak more, and some of it might be an opportunity for us to bring in subject matter experts to tell us what's going on, and maybe those are moments to just take things in and learn and go and reflect and bring those back into other conversations we are having, either in country, regionally, or back here. So this has been a great, great opportunity to learn. I've also learned a lot from the discussions here and the lessons from Uganda and our colleague from, was it?
Malaysia.
Malaysia, yes, Malaysia. I think there is also another component of the HIV treatment story that we are keen to bring to life in this space. So please stay tuned. And that is HIV cure. I think the progress in research and science on the HIV cure is progressing rather fast. Our voices remain not as active in the topic. And we at GNP Plus are now launching a HIV cure desk to get us all organized around HIV cure discussions in the research, and all of these things tie together, because I think the HIV treatment story gives us an opportunity to speak about access to the treatment itself, what the treatment will do, which is save our lives, keep us healthy and productive, what the treatment will do for our community, assure us of an opportunity to contribute to HIV prevention. But the bigger opportunity also is a different story to the HIV story, not that one that ends with AIDS deaths, but ends with a cure. So let's all come together to this space to continue learning. Let's take what we have here into our different discussions. It's a pleasure to always collaborate with you all. And thank you all for your leadership and your service to our community. Thank you so much, and back to you, Inad.
Thank you so much, Florence. We will be sharing the presentations with you. Give us until early next week to collect all the presentations. Thank you so much for your time. This has been one of the longest convenings that we had. Very informative, very engaging. Thank you so much, and let us all be healthy. Bye-bye. Good night. Good night. Good afternoon.